Welcome to all the Kasogians and all the obstetrics and gynecologists throughout Karnataka. We would like to start the program by lighting the lamp. Oh, Arun, could you please seeking the blessings of Lord Ganesha.
आरोग्यं धनसम्पदः शुभं त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते।
Hello.
Yeah.
Thank you, Arun. So now we would like to start the webinar. I would like to invite Dr. Shobha Gudi.
Arati, just a minute. Arun, the lamp was not seen, Arun. Only your screen was seen.
Music.
We did not.
Audio.
Only music came, and the screen was your laptop screen.
Okay.
There must be a video of the lamp being lighted. No, let us do it the proper way. Okay.
Okay, shall I restart, ma'am?
Yeah. Hardly a second.
Settings also.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते।
Okay, I think time to proceed. Yes, Arati, please. Yeah, it's okay. Arati?
Yeah, I would like to invite. Yes, ma'am. Am I audible?
Yeah.
Yes.
I would like to invite our Secretary General Kasoga, Shobha Gudi ma'am, to give the welcome address.
Can everybody else be muted, please? Arun? Yeah. Hello?
Yes, ma'am.
Can we have the gallery view? We don't need a screen share right now. Okay, it is a proud privilege for me to welcome you all for the very first webinar of this year's Urogynecology Committee, headed by the chairperson being Dr. Vijay CR. I have known Vijay for many years in Bangalore Society, has been a very hard-working person for Bangalore Society of OBG, and we hope to see him in official position in BSOG as well. He already has completed half the journey there as well. So Vijay has been an ardent follower of urogynecology and has specialized in it, and I'm happy to see the committee in his hands. And as Dr. Durgadas was mentioning, he has been able to gather a real galaxy of speakers. I welcome all seniors here, Sri Mani Madam, and my very good friend, Dr. Nagaraj Venkatesh, and several others. Of course, Shobha is there, and of course, Sudha from Mysore. I can see Nagaraj sir as well. So without wasting more time, after welcoming you all for this very pleasant afternoon communion session filled with knowledge, because believe me, any session delivered by Dr. Rajamaheshwari will directly translate into practice if you are doing urogynec surgeries. She is an excellent teacher. So over to our president, Dr. Durgadas Asrana, for his address, and then the sessions will start. Thank you very much. Thank you.
Good evening, everybody. At the outset, I thank and congratulate Dr. Vijay Kumar for inviting me for this session. As we all have seen Vijay Kumar, a person with passion, person with forethought. the subjects what he has selected today is one of the very common thing, prolapse. Each and though the incidence of prolapse is reducing, a lot to be known about the prolapse. It is not the hysterectomy, what we used to learn in the good old days, hysterectomy and AP repair. It is the compartment wise repair, which needs to be understood by knowing its anatomy and the function. For to deliver such a to deliver such a important topic, she has selected the gem of the personality, Dr. Raja Maheshwari. She is not only a national figure, she's an international figure. Madam Kasoga is honored by your presence today. Equally, I thank Vijay Kumar not for inviting such a galaxy like Dr. Sharma and Dr. Karishma, Dr. Kavita Banswal, our own Dr. Sheila Mane, Dr. Ventesh Prasad, Dr. Srimani Rajgopal. We have a galaxy of speakers today, and I ask the Kasogians to log in large numbers and make the best utility of this program. One word of thing to Vijay Kumar, as it stand to all the webinars of Kasoga, no time is wasted. 4 o'clock the session, prayer song means by 4:48 the scientific activity should start. This is what my vision is. Thank you, Vijay Kumar, for, once again, and all the best for the program. Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. Dr. Vijay, over to you to start the session.
I thank our President Kasoga, Dr. Durgadas sir, and the Secretary Shobha Madam, and the Treasurer for giving this opportunity to chair the Urogynecology Committee for 25-27. It's my great privilege that today I am organizing this webinar with our esteemed teacher, Professor Raja Maheshwari Madam. I have learned a lot from her about the urogynecology, and this I want to part it with all the consultants of Karnataka. And I am humbled and thrilled that Raja Maheshwari Madam is with us to deliver the lecture. Thank you, Madam. Thank you. And as Dr. Durgadas sir said, we will keep up the time during the webinar. Not only that, we will organize the scientific session in such a way that it will be very interesting and it will be useful for the gynecologist in managing the various urogynecological problems and management. I thank and over to Dr. Aarti Sridhar.
Thank you, sir. Thank you, sir. Thank you, sir. Again, it is echoing, no?
Again, it is echoing, no? I think you have logged in with two devices, probably. Aarti, you see that? Have you logged in with the two devices?
Yes, sir. There is little internet connectivity issues.
No, you close the video and keep the audio on.
Yes.
Close the video, keep the audio on. Don't log with the two video,
Yes,
two systems. Okay?
Yes, sir. Yes, sir. So the first session is on functional anatomy of pelvis, and I would like to call upon our speaker, Dr. Karishma. And for this, we have the chairpersons, Dr. Kavita and Dr. Aarti. So Dr. Karishma Thairani, she is a consultant, Center for Urogynecology and Pelvic Health. Her areas of interest, urogynecology, pelvic reconstructive surgery, and menopause. And she will be dealing with functional anatomy of pelvis. Over to you, ma'am.
Good afternoon, everybody. I am Dr. Karishma Thairani. It is my proud privilege to be invited here as a speaker for this webinar. And I would like to thank all the members of the organizing committee. Like Dr. Aarti already introduced the topic, my topic today is functional anatomy of the pelvic floor. Let us begin. As sir said, we have to stick to time. So this is a picture of the Air Force officers from the Second World War. What they're trying to do here is they're trying to see what keeps the parachute suspended in the air, because if their planes are shot down, their lives depend on this parachute. I feel as urogynecologist and gynecologist, we are also like them. We are constantly looking at what keeps the organs in the pelvis well supported so that our prolapse repairs do not fail. And this is where the role of functional anatomy comes. So today the objective of the lecture are to understand the functional anatomy and how it impacts our clinical diagnosis, to know the most critical components of pelvic support, and to help this knowledge optimize our surgical repairs and reduce failures. So let us look at the most controversial question: what is the most critical element in pelvic support, and if there is any? So we know that the pelvic support is basically contributed by the bony elements, the muscular elements, and the fascial elements. Let us look at each one of them one by one. So we know the pelvic the articulated pelvis consists of three bones: the ilium, ischium, and the pubis. But it is not just the way the articulated pelvis is designed, but the way it is oriented in an erect human female. Because of the lordosis of the spine in a female, the pelvis is oriented slightly tilted anteriorly in such a way that the anterior superior eye-like spine and the pubic symphysis lie in the same plane. Now, what this does, because of this orientation, all the increased intra-abdominal pressure falls on the bony elements, on the pubic symphysis, and not on the pelvic floor down below, thereby protecting the pelvic floor, the muscles, and the fascia and the connective tissue from the increased intra-abdominal forces. This helps in preventing prolapse in women. Let us look at the next component, that is the muscular component. We know that the pelvic floor comprises of the most important muscle in the pelvic floor is the levator ani. It is supplied by the directly from the S2 to S5 nerve roots to the nerve through levator ani. Now, this is the vision that a vaginal surgeon gets when he or she is operating of the pelvic floor. We know this. These are the different components of the levator ani muscle. To understand and to visualize it better, let us just look at the pelvis from above. Let us look at this view. Now, this is the pelvis. If one of us is looking inside the pelvis from above, we know that the pelvic side walls are formed by the obturator internus muscles. Posteriorly, we have the piriformis and the coccygeus muscle. Now, rest of this is the levator ani. Let us look at these components. The first component is the pubococcygeus muscle. Pubococcygeus is now also called as pubovisceralis because it gives out three attachments: one to the perineum, puboperinealis; one to the vagina, pubovaginalis; one to the anus, puboanalis. Because of its three attachments, now we don't use the word pubococcygeus, we call it the pubovisceralis. The second is the puborectalis. We all know the puborectalis muscle. It goes behind the rectum, forms the anorectal angle, helps in fecal continence. And the third component is the iliococcygeus muscle. Now, the iliococcygeus muscles of both the sides form a very important structure called the anococcygeal raphe. This is also called as the levator plate. Why is this important? You see, there is this little hole in the levator ani muscle. This is the urogenital hiatus, the urethra, the vagina, and the rectum. All three of them pass through this hole and come and open towards the outside. Now, because of this anococcygeal raphe, or the levator plate as we call it, all these structures rest on it. That is to say, when you're visualizing vagina is not an erect structure. Only the proximal or only the distal 1/3 of the vagina is vertical. Rest all of the vagina is horizontal, lying on the levator plate. So this is how the vagina lies over the levator plate. Now, when a woman is standing, because of the tonic contraction of the levator muscle, the urogenital hiatus is kept closed and the levator plate is taut and horizontal, forming a bed for all these pelvic tissues so that they are supported. So this is in a woman. As soon as the intra-abdominal pressure rises, the urogenital hiatus, the levator contracts, the hiatus becomes narrow, and the levator plate acts as a back valve and does not allow the intra-abdominal pressure to be transmitted onto the pelvic floor. Now, what happens if the levator plate is not like this? It's saggy. If the levator plate is saggy, there's a levator muscle dysfunction, then all the intra-abdominal pressure will be transmitted down towards the opening. The urogenital hiatus will expand in size. So the size of the urogenital hiatus, the small size of the urogenital hiatus is maintained by the tone of the levator ani muscles. This is a very important point to begin with here. So what happens in the case of levator injury? There's a neuromuscular injury to the levator. There is sagging of the levator plate, lengthening of the hiatus. Vagina becomes vertical. From lying from the horizontal position, it becomes vertical. This puts unnecessary strain on the connective tissue elements, the ligament and the fascia, which causes prolapse. This brings us to our third component of pelvic support, that is the pelvic fascia. Now we know that the pelvis has different types of fascia. One of them is parietal fascia. As the name suggests, it is a regular arrangement of collagen fibers which invests around the striated muscle. So let us look at this fascia here. The first here is the arcus tendinis levator ani. It is nothing but a condensation of the fascia over the obturator internus muscle. It is called arcus tendinous levator ani because some components of the levator ani take its origin from this. The next very important landmark is arcus tendinous fascia pelvis, which we also commonly call as the white line. Now, this white line is very important from the surgical point of view as well. It is often difficult for the junior surgeons to identify the white line when you're operating on a patient. So this is a cadaveric video where this is the cut section of the pelvis. And you can see here the extension of the white line. The white line extends from the ischial spine to the pubic tubercle. So this is the extension of the white line from the ischial spine to the pubic tubercle here. So this white line forms the lateral attachment of the fascia, which we'll be studying, which we'll be talking about as we move forward in the lecture. Arcus tendinous fascia rectovaginalis is nothing but the posterior attachment or posterior segment of the arcus tendinous fascia pelvis, posterior extension. Let's go to the next slide. This brings us to the visceral fascia or the endopelvic fascia. The visceral fascia is subperitoneal perivascular loose areolar tissue. It is not as well formed as the parietal fascia that we were talking about. The most common types of this fascia are the pubovesical fascia or the pubocervical fascia. This is the fascia that you dissect when you're doing a cystocele repair. Second is the rectovaginal fascia. This is the fascia between the rectum and the vagina, the fascia that we dissect and plicate when we are doing a rectocele repair. The next two are the cardinal and the uterosacral ligaments. For anatomical reasons, they are also put under this classification only. So let us look at this. This is the pubocervical fascia, the fascia that you dissect when you're doing a cystocele repair. The rectovaginal fascia, the fascia that we dissect when we're doing a rectocele repair. Now, it is very important to understand that these facial attachments are not independent of each other. All these fascia, they come and merge together at the level of the cervix, forming the pericervical ring. This is the second most important learning point here. You can see the uterosacral ligaments here, the McEnroth ligaments laterally, the pubocervical fascia anteriorly, and the rectovaginal fascia posteriorly. All these fascia, they together combine and form the pericervical ring, which is basically the point where all these fascias are merging. So all these facial attachments together, the pubocervical fascia, the rectovaginal fascia attaching to the white line on both sides, the McEnroth and the uterosacral ligaments here, they form a trampoline-like structure for all the pelvic organs, supporting them so that undue stress is not put on the pelvic floor. So this is how the connective tissue elements help in supporting the muscular elements of the pelvis. Now, what happens when these fascias have defects? We know if there is a defect in the pubocervical fascia, we'll have an anterior compartment defect or a cystocele. Dr. Raja Maheshwari is going to take an extensive lecture after this, and she'll be covering this in great details. But just to look at it, a cystocele can be because of the defect is not necessarily always in the center of the fascia. The defect can also be laterally. You can see both of these are cystoceles, but both of them look different. Here, there are no rugosities, whereas here you can see rugosities. And sometimes there can be facial detachment from the level of the apex, leading to an apical cystocele. So knowledge of these defects is very important. If you miss a lateral defect and you just do a central plication, the prolapse is going to recur. So therefore, this knowledge of the facial defects and the location is very important. Similarly, in the posterior compartment, you may have a central defect leading to a central rectocele. You may have an apical detachment here. So you can see here that the fascia is detached from the apex. And similarly, you can have a detachment of the rectovaginal fascia from the perineal body, leading to perineal hypermobility. So knowledge of these defects is extremely important. Similarly, in the apical compartment, you may have a uterine descent, you may have pulsion enterocele or a vault prolapse. The next component is the pelvic ligaments. We know there are different ligaments in the pelvis, and some of them are of surgical importance to us, like the Cooper's ligament, which we use for Birch's corpus suspension, pectineal ligament, which is now used for vault suspension in pectopexis, sacrospinous ligament, which we use for vaginal suspension or sacrospinous hysteropexis, anterior longitudinal ligament, which we use for sacrocolpo or sacrohysteropexis. Let's come and look at the perineum. Let's come out and look at the perineum. We know that this diamond-shaped structure extending from the pubic symphysis to the coccyx is the perineum. The perineum is basically divided anteriorly into a urogenital triangle and posteriorly into an anal triangle. Now, if we look at the urogenital triangle first, the urogenital triangle is divided into a superficial perineal pouch and a deep perineal pouch. If you look at the superficial perineal pouch, if you follow the Scarpa's fascia from the abdomen and bring it down, where it forms the coli, if you remove the Colles fascia, that continuation of Scarpa's to down below, you will enter the superficial perineal pouch. The superficial perineal pouch consists of the ischiocavernosus muscle, the bulbospongiosus muscle, the Bartholin's gland, and the female erectile tissue. Now, when you're doing a Bartholin cystectomy, this is the superficial perineal pouch is where we are operating. Now, why are all of us so scared of doing a Bartholin cystectomy? Because it bleeds a lot. And the reason it bleeds is because this erectile tissue is lying just posterior to it. That is why this area is extremely vascular and it bleeds. This membrane here is the perineal membrane. This helps in urethral stabilization and continence. Once you go below the inferior fascia of the urogenital diaphragm, you enter the deep perineal pouch. The deep perineal pouch has the urethral muscles, the sphincter urethrae, the compressor urethrae, and the ureterovaginal sphincter, along with the deep transverse perineal muscle. These muscles help in maintaining continence. Coming to the anal triangle, in the anal triangle, we have a very important structure, which is the perineal body. We know that the perineal body is also called as the central tendon. It is formed by the superficial transverse perineal muscles. It has attachments from deep transverse perineal muscles, bulbospongiosus, external anal sphincter, longitudinal muscle of the anal canal, the rectovaginal septum, and the perineal membrane. Perineal body forms a tough level 3 support of the pelvis. It redirects the abdominal pressure and dissipates gravity to prevent expansion of the urogenital hiatus. That is, it does not allow the urogenital hiatus to expand further. You can see two pictures here. In one, the perineal body is deficient, and in one, it is completely absent. It's also known as the cloacal deformity. Now, if we put all of this together, like the way D. Lancy described his supports, the level 1 support is provided by the uterosacral and the McEnroth ligament. The level 2 is provided by the lateral attachment of the pubocervical and rectovaginal fascia to the arcus tendinous fascia pelvis. And the level 3 is given by the perineal body and the perineal membrane. What is important to understand that these levels are not independent of each other. They are joined together, and the pericervical ring forms the apex of where all these supports merge. There are So basically, supports of all the three compartments converge at the pericervical ring. There are studies which have demonstrated that if you simulate the apical support, 55% of anterior compartment defects and 30% of posterior compartment defects reduce in size. That is, most of them will basically reduce in size once you correct the apical support. Maintaining the integrity of pericervical ring is important, and repair of the apical support is cornerstone of complete pelvic reconstruction. So what are the most important factors? The most important factors are the apical suspension, identification and correction of paravaginal defects, and correction of the hiatal enlargement. In the presence of levator avulsion, if there's complete levator avulsion on one side, or there's levator injury, in those cases, native tissue repairs may be problematic. Levator damage is currently not repairable by surgery, and uterus only plays a passive role. There is no role of uterus per se in causing or increasing the prolapse. Now, whatever we have learned, let us use that knowledge. Let us basically make anatomy as a GPS system to understand what we look at here in this picture. We can all see a cystocele here. This much we all can identify. We can see that the perineal body is tipped down, it is shortened. But we can also see here that there is something which is attached here, which is basically detached on this side. So if we look at the MRI image of this patient, we can see that there's a complete levator avulsion on this side, whereas it is present on this. So when we use our knowledge of anatomy while we are seeing the patients, we'll be able to diagnose them better. In the end, I would like to conclude by saying that anatomy is the foundation of pelvic floor surgery. We see what we look for, and we only look for what we know. Thank you.
That was an excellent presentation, Dr. Karishma.
Thanks so much.
So you've made anatomy more easier for all of us to understand.
Thank you so much.
In this session, we actually have a 3 minutes quiz, which will be taken by Dr. Rashmi, who is the chair of quiz committee. So with your permission, sir, we'll go ahead with the quiz.
Please, Dr. Aarti. I welcome Dr. Rashmi.
Dr.
Hello, sir.
Rashmi, over to you.
Yeah. So I'll be just sharing my screen.
This is a good initiative taken by Dr. Rashmi to have a quiz in between the scientific sessions. This will keep the students occupied, and it will make the enthusiastic PGs to actively participate in the scientific programs. I welcome you, Dr. Rashmi.
Thank you,
Vijay,
sir.
my suggestion. Vijay, my suggestion, I told you. Club together.
Thank you, Durgada, sir. Thank you, Vijay, sir.
Ultimately, the credit will go to the president of the syllabus.
No, I told you to make this more colorful. Please,
Yes,
sir.
Yes, sir. Yes,
True,
sir.
sir. True, sir.
So I wouldn't take much time. There are 5 important questions which have been suggested by Dr. Karishma as well. And there are certain rules I would like to say. 30 seconds will be provided for each question. I request all the participants to kindly note down the answers and post all the answers together. So for example, 1 is A, 1 is B, like that. You have to write 1 is this, 2 is this, 3, 4, 5. Once you have read all the 5 questions, just write down them and post them together, because I'll be assessing the chat box, and the first one to post and all the correct answers, they'll be getting a certificate of appreciation. So all the questions put together, in the end, we are going to assess them all together. So here are the questions, and I'll be keeping the timer as well. So this goes for the functional anatomy of the pelvis. Question number 1. Participants, kindly note. You have 30 seconds to note down. Do not post the answers now. After all the 5 questions, you have to post all the 5 question answers together. Question number 2. Question number 3. Question number 4. Question number 5. So I request all the participants to post the answers together in the chat box. 1, this, 2, this, 3, 4, and 5. So the first one to get all the correct and posting it early.
Thank you. Thank you, Dr. Rashmi.
Thank you. So should I share the answers now or later, ma'am?
We'll share it at the end of the session. Yes, sir.
And sure.
Yeah.
Okay. Thank you, everyone.
Thank you, Durgadas sir. This was an excellent initiative, and it will keep all of us active throughout the session. Yeah.
Yes.
So now we will have the much awaited.
We have 2 more talks and 2 more quiz coming up, ma'am. After every talk, we'll have 2 more coming up.
Rashmi. Thank you. So now we have proceeding towards the second topic of the day, and we welcome Rajamaheshwari Madam for this session. And I would like to invite the chairpersons, Dr. Shobha Gudi and Dr. Rekha Rajendra Kumar. Shobha ma'am, would you please
Yeah, I'm here. Can you
introduce
put the
Rajamaheshwari
CV
madam?
for Raja
Yeah.
Maheshwari madam? So a very, very warm welcome to Professor N. Raja Maheshwari to Kasoga. Though you are not present here physically, madam, we can feel the vibes already of your excellence. Madam is currently the head of Department of Urogynecology at Female Urology Clinic at Chennai. OMR Tharai Pakam, Chennai. She is Director of Advanced Center for Urogynecology, Chennai, and also the Chair of Women of Urology, WOU, Urology Society of India. She is Chair for the Education Committee of the IUGA as well, and the President of URP SSI. Very, very well established practice at Chennai, and more important than that, has trained hundreds of gynecologists for this specialization. She is certified trainer, in fact, for prevention and repair of perineal trauma episiotomy through coordinated training, and that is PROTECT. She is a visiting surgeon to the UAE and a member of National Board of Examinations also. So we welcome you, madam, your illustrious personality here. I'm very, very blessed to have your presence, and we are eagerly awaiting your talk. Thank you for being here. The floor is yours, madam.
Good evening, everybody. Am I audible to you?
Madam.
Yes,
Yes,
ma'am.
madam. You are
Yes,
very
ma'am.
much audible.
Is my slide seen?
Look
Not
good.
yet. Yes,
Yeah,
ma'am.
now it is seen.
Okay. I just want to make sure whether I'm audible and my slides are seen. Okay.
Sure, ma'am.
I
Yes,
hope
ma'am.
both are fine.
Yes,
Okay. At the outset, I would like to thank the Karnataka Society, the President, Secretary, and the Dr. Vijay Kumar, who is the Secretary of the Urogyne Committee, and all the esteemed office bearers, members, dignitaries, and the other friends who are there listening to us. Thank you very much for being patient to be with us. I'm going to talk about the anterior compartment defects. By the end of the session, you will know why did I choose this topic. So the anatomy was very well described, and it was a great presentation by Dr. Karishma. Congratulations, Karishma. You're doing an excellent job. And let me start with the anterior compartment defect. We know that the anterior compartment has both the urethra and the bladder. And as per what Professor John Delancey has made us understand, that we describe prolapse in level 1, level 2, level 3, and 3 levels. And also we incorporate the anterior compartment, the middle compartment, and the posterior compartment along with that. So it is also absolutely essential for us to know the supports at different level 1, level 2, level 3. And we need to look at the supports of bladder and vagina as well. So how common is anterior defect or anterior compartment prolapse? So Versi et al. Has shown in their study 51% of the peri or postmenopausal women had some degree of anterior vaginal wall prolapse. Honda et al. Has reported a prevalence of 24.6% among the postmenopausal women. So we all have seen any number of the bulge in the anterior vaginal wall, different size, shape, duration, and how common is the anterior wall bulge? It is twice more common than the posterior compartment defect, and it is 3 times more frequent than the apical prolapse. So the only thing is, in the early 90s, it is said the only problem left unresolved in plastic gynecology was the permanent cure of the cystocele. So, ladies and gentlemen, regarding the terminology, all those years we have been using the word cystocele, and it is recommended to use the terminology anterior vaginal wall prolapse. So, there are a few facts that we should recall and remember. That is, the surgical, the patients with prolapse who need surgery, and their number increase with increase in their age. And all over the world, it is said 11% of the people with prolapse are undergoing surgery. 81% of the surgical repairs are addressed to the cystocele. And the most interesting thing is the cystocele repair fails up to 41% of the cases frequently. So assessment can be unique. Management may pose challenges. The two things that one has to remember is the most common site of initial prolapse and most common site of recurrence in prolapse surgery is the anterior vaginal wall prolapse. So, ladies and gentlemen, why is this? Can you minimize this? I'm just minimizing this. No, why is this the cystocele or anterior vaginal wall prolapse is more frequent, and why do cystocele repairs fail? So, ladies and gentlemen, what is wrong with the anterior vaginal wall support? Is the anterior compartment not well supported as the posterior compartment, by the levator plate by countering the effects of gravity and increase in abdominal pressure. Or the attachments of the anterior compartment to lateral pelvic side wall and apex, is it weak? Okay. Okay. The next point is the anterior compartment is more elastic, less dense than the posterior vaginal wall? Or is the anterior wall more susceptible to damage during childbirth or weakening with aging or with loss of estrogen? So the reason for failure of the anterior repair described by George White way back is failure to restore the normal support of the bladder and irrational excision of the anterior vaginal wall. So we need to remember the supports, different levels, the apical support and the level 2 supports, anteriorly the pubocervical fascia and the distal support. We should be aware of all these things. We are keen to know about the appropriate restoration of the support of the vagina, the cervix and the bladder. Ladies and gentlemen, what is the reason for the descent, the anterior prolapse, anterior vaginal wall prolapse? See, it may be a defect. You see, this is the pubocervical fascia, anteriorly attached to the pubic bone, laterally to the white line, and it goes to the pericervical ring. And this greenish one is that. And it is in a trapezoid shape. So when there is a defect in the fascia, there will be a bulge. It can either be a defect or it can be a detachment. So ladies and gentlemen, there can be a midline defect, central defect, or a paravaginal defect or lateral defect, transverse tear, proximal, distal. There can be mixed tears, and particularly in post-hysterectomy cases, the prolapse can be of the apical enterocele or can be even a true anterior enterocele. Ladies and gentlemen, what we have been taught, what we have been doing all those years is the simple plication of the pubocervical fascia. That is what we learned. Unfortunately, the occurrence of this central defect that can get cured by the plication occurs only in 5 to 15% of the cases. You see, this is the pubocervical fascia. There is a defect in the fascia. The bladder comes down. So while you focus on approximating and strengthening the fascia, this might get minimized or reduced. So if you see vaginally, there can be a midline defect. That will be the central defect. And there can be lateral defect. That will be the paravaginal defect. And this will be the transverse defect. So how do we identify the central defect? So there will be a bulge, which is persistent even with the support. And the urethrovesical junction may be hypermobile. And rugosity will be absent. You see this picture? And do remember this. It will be absent in central or midline defect. Next comes the type here. You see, there is detachment of the pubocervical fascia from the pericervical ring. So for this patient, if you go on be just plicating the fascia, it is not going to help the patient. We will be rewarded with recurrence in the postoperative period. So what we need to do is we need to reattach the fascia back to the pericervical ring. The picture shows you how when there is a detachment of the pubocervical fascia, how the bladder comes down. Okay, this is shown by Professor John Delancey. This is a trapezoid in situ, and when the transverse attachment is intact, you see there is no bulge. When the transverse attachment is lost, you see a bulge in the anterior vaginal wall. So regarding the paravaginal defect, the lateral cystocele or displacement cystocele, which is the most frequent type of cystocele or descent we encounter, it occurs as high as 70 to 80% of the cases. So you see that this picturesque diagram showing you how it is attached laterally. So the level 1 support is suspending it. Level 2 support is attaching it, and level 3 support is fusion. So do remember all these things. This paravaginal defect can be unilateral as shown here, or it can be bilateral. So when you look at the patient from the abdominal view, you can see that midline defect, lateral defect, transverse defect. So this will be the white line. So ladies and gentlemen, the pubocervical fascia is nicely attached to the white line. When there is a separation of the fascia from the white line, what you get is called the paravaginal defect. So logically, you need to reattach the fascia back to the white line instead of stopping short with plication or simply by restoring the transverse attachment. This is something when one has to remember. How do we identify the paravaginal defects? So there will be midline rugosity. You see the rugosity here. So you see the previous one where there was absolutely none. And you see there can be loss of anterolateral sulci, and the support test will be positive. What is the support test? If you keep an open forceps and reduce the bulge, the whole bulge disappears. That is called the positive support test, which points out the patient has paravaginal defect. Ladies and gentlemen, one should remember there can be combination of defects or mixed defects. Just because you have a bulge in the anterior vaginal wall doesn't mean that that is an isolated defect. There also can be level 2 posterior defect, which we traditionally call it as rectocele, or there can be a defect in level 1 with an apical prolapse, or there can be multi-level defects. So combination of defects and mixed defects should be remembered and should be looked for while examining the patient. So what is the objective when you are planning for surgery? So if the patient with the anterior vaginal wall prolapse is symptomatic and with the size stages 2 or more, only then we offer surgery. If she is asymptomatic, we are not offering surgery. So what would be our objective? We need to relieve the symptoms of bulge. We need to relieve the symptoms of bladder bowels symptoms because of the bulge and functional derangement. There can be disturbances in the bladder bowel function. So we need to relieve her, and we should see that no new defect, no bladder or bowel symptoms occur. We should preserve the sexual function and improve the quality of life. So our aim should be restore anatomy by correcting the defects. You plicate, you reattach the fascia, either to the pericervical ring or to the white line. And there are people who believe in correcting the weakening or attenuation of the fascia by superimposing the native tissue repair. So what are all the options that we have? We have the vaginal option, we have the traditional native tissue repair, anterior colporrhaphy, vaginal paravaginal defect repair. There can be, it was in practice, not now, the usage of mesh or biologic material to augment the native tissue repair. And people have even used pre-designed mesh kits using the transoperator approach. And we have the classical abdominal approach, laparoscopic and robotic approaches. Well, what is this? So what is this traditional native tissue repair, anterior colporrhaphy or anterior repair? What we should do is, it is meant to plicate the fibromuscular layer of the anterior vaginal wall. Do remember, we are not simply just approximating only the pubocervical fascia. It includes the fibromuscular layer of the anterior vaginal wall. Number 2 is the site-specific defect repair. That is, you identify the defects in the specific sites and then plicate the fibromuscular layer of the anterior vaginal wall over there. And the third one is reinforcing the fibromuscular layer of the anterior vaginal wall using the graft material, sometimes synthetic or biodegradable. The way back, the Kelly was the first person who described the native tissue repair, anterior colporrhaphy, and he reported success from 80 to 100%. So what was that we all believed that Kelly did was incision was made, pubocervical fascia is dissected out, and he made an effort to placate it. That is what we think. We really didn't know what exactly Kelly did, because he might have done a lot more than that, because in the hands of other surgeons, the same steps has resulted in high failure rate. So for those cases, and the central defect repair of the pubocervical fascia is there, plication may be sufficient. But this is the video showing you the attempt to do the plication of the pubocervical fascia. What we do normally is make a midline incision, dissect the fibromuscular layer of the from the vaginal wall, and we normally use PDS for approximation of the fibromuscular layer. And you can use the Vicryl or polygladin for the closure of the epithelium. So you can imagine such a big prolapse. And in those days, we were courageous enough to repair even such huge defects with the plication of the pubocervical fascia. Nowadays, we will hesitate to do that, because this is not going to offer a long-term efficacy for this patient. So this is just to show you how the midline plication can be done using the delayed absorbable suture material, but ideal would be to resort to additional techniques. Next comes what are the other modifications you can do for the anterior repair. You can make different incisions. We normally believe in using the hydrodissection. The lateral extent of dissect is up to the pubic rami, and you can combine hysterectomy or wall prolapse repair or midurethral slings along with the anterior repair. So what really has happened is Weber in the early 20th century reported 70% failure rate with native tissue repair. Sand et al. Reported 43%. And Olsen et al. Reported the need for reoperation in almost 30% of the cases. Because of that, the usage of mesh came into practice in the early 2000s. People started using a patch of mesh as an augmentation of the native tissue repair. Then they developed a transobturator approach. Pre-designed mesh kits came. All of us we tried it, but then later we realized that it is the mesh which is responsible for so many complications. So the mesh exclusion rate was 11.5%, and need for surgery for mesh-related complication was as high as 7%. So because of that, US FDA issued a warning, and majority of the polypropylene products were withdrawn from the market. Then they even introduced a newer mesh, lightweight mesh, absorbable mesh, biological grafts, all those things to minimize the complications. But the current place of usage of mesh in prolapse surgery, anterior compartment defect repair, is only when you have a recurrent anterior wall prolapse, and when you explain the mesh-related possible potential complications of mesh, and provided the patient accepts it, then you can go ahead and do this. And there is level 1 evidence and grade A recommendation for the usage of polypropylene mesh, but only in recurrent anterior vaginal wall prolapse. What about this restoration of transverse attachment? You see, for this, you will resort to the plication. For this kind of detachment, it is not enough you simply placate it. So here we are just showing a video in which we just did the aquadissection, mobilizing the fibromuscular layer along with the pubocervical fascia. Having mobilized, almost you just skin it from the vaginal epithelium, and this is what we need to achieve. What we do is use the PDS sutures you take the bites on the pubocervical fascia, then on the uterosacral ligament, then on the posterior vaginal wall, and go to the opposite side, uterosacral ligament, and then take the bite on the opposite side, pubocervical fascia, and continue it. Do something like a circumferential closure, but at the same time, which attaches the pubocervical fascia to the newly created vault. Okay, this is what we do. Even with one single suture, the whole defect gets almost completely closed. But we also reinforce and bring it out through the vaginal wall, and later we can approximate after the approximation of the vaginal wall. We also combine it with the plication as and when there is a deficiency. So what is important for you is, it is absolutely essential for you to restore the transverse attachment by reattaching the fascia back to the pericervical ring. That minimizes the recurrence of cystocele in future. Let's see this lateral defect or displacement cystocele. Here you see this is the detachment of the pubocervical fascia from the white line. So this detachment should be corrected by reattachment. So how can we do it? You can do it formally by abdominal laparotomy or by a robotic or laparoscopic technique. But can we achieve it vaginally? To start with, surgeons were trying to repair it by vaginal approach. There is something called 3-point closure. What they did, they took the point at the level of the arcus tendinous fascia pelvis. It is very difficult to reach the arcus tendinous fascia pelvis through the vaginal approach. And they took a bite, then took a bite on the pubocervical fascia, and then on the fibromuscular layer of the vaginal wall. On either side, separately, they will take the bite and then finally tie it. But do remember, this is the defect, what you see from above. This is what you are trying to repair through the vaginal approach. So, Professor Shull is a person who introduced the technique, and considering the complications, they have given up the vaginal repair of the paravaginal defect. So, what is recommended nowadays is the abdominal paravaginal defect repair, which offers quite a high success, as high as 97% of the cases. So, various reports have shown an excellent report. And there was a comparison between the abdominal sacrocolpopexy, abdominal paravaginal defect repair with the Birch-Colfer suspension, and it is compared to the vaginal approach, sacrospinous ligament suspension, and vaginal paravaginal repair. And the evidence, level 1 evidence, has shown superior outcome with abdominal approach and repair compared to vaginal repair. And there is grade B recommendation for that. Regarding the laparoscope and robotic repair, at the end of 1 year follow-up, laparoscopic paravaginal defect repair has shown a failure rate of only 2.3%. But at the end of 5 years, and they have reported the recurrence beyond the hymen as high as 24%. It is possible to do adjunct procedures along with the laparoscopic and robotic repairs. What you can do is, if there is a need for Birch-Colfer suspension, you can combine it with that, and the apical defect can be corrected by apical suspension. So one important thing I would like you to remember, all of you, is if there is a vaginal wall descent bulge beyond the hymen, then what does it mean? It means there can be an associated loss of apical support, which is very common because apex offers significant support to the anterior vaginal wall. So those patients would require concomitant repair of the anterior defect and apical defect. Elber et al., by doing the apical suspension along with the anterior repair, has shown, and he has demonstrated, he has significantly reduced the reoperation rate from 20% to 11%. And this has the grade B recommendation. When there is an associated defect in the apex and level 2 anterior defect, they must be combinedly repaired. Then next is you need to remember about the mixed defects. So there can be level 2 anterior defect, level 2 posterior defect. There can be level 2, level 1 defect and level 3 defect. So when you want to minimize the recurrence and avoid all the disappointments of your patient in the postoperative period, we need to look into all these aspects and do the repair as per that. What is the important disadvantage, greatest disadvantage of sacrospinous ligament suspension? That is, see, the success rate of apical suspension is influenced by the, it interacts with the concomitant vaginal apical suspension. In cases of sacrospinous ligament suspension, the recurrence, particularly in the anterior vaginal wall, is as high as 37%. That is the reason this sacrospinous ligament suspension fell into disrepute, and we are hesitant to use it as the primary procedure for prolapse cases. Ladies and gentlemen, at the same time, if you take the high uterosacral ligament suspension, and what you do is you suspend the vault to the uterosacral ligament at the intermediate part of the uterosacral ligament, along with the pubocervical fascia anteriorly and the pubocervical fascia posteriorly. By doing this, you not only suspend the apex, but also the pubocervical fascia and the rectovaginal fascia. The recurrence reported with this kind of repair in the anterior compartment is as low as 3.5%. Ladies and gentlemen, and regarding the reasons for recurrence, failure to address specific defects in the vaginal support, overlooking the mixed defects or the combination of defects, failure to recognize and correct the coexisting apical defect, failure to address the high-risk cases. All these are hypothesized to be the reasons for the recurrence. And it is also true there is a significant correlation between the apex, paravaginal part and the hiatus size. So any complete anterior repair involves not simply plication, it is reattaching the pubocervical fascia back to pericervical ring or the white line, along with supporting the vaginal apex and reducing the dimension of the genital hiatus. And this was very well said by Dr. Karishma. I request you all to remember that. And the next important thing is, what did we miss all these years? We see bulge in the anterior vaginal wall. What is that we are missing here? We always look at only the anatomical defect. We don't look into the functional consequences. Any cystocele or prolapse or rectocele, there can be associated lower urinary tract dysfunction. There can be bladder outlet obstruction, detrusor dysfunction, and urinary incontinence. See, the prolapse, either anterior, apical, or even posterior prolapse can result in bladder outlet obstruction. If it is a low-grade prolapse and the prolapse lies within the hymen, it may remain asymptomatic without any significant outlet obstruction. The low-grade prolapse, there was only up to 3% of the cases who had bladder outlet obstruction. On the contrary, in advanced cases, 70% of the cases had the bladder outlet obstruction. So, whenever there is a huge anterovaginal wall descent, with or without uterine descent, there is likely to be obstructive voiding symptoms with increased residual urine, but rarely it results in hydronephrosis or renal failure. On the contrary, the small cystocele, not a very big one, will have less of obstructive symptoms and are likely to have more of stress urinary incontinence. So it is the report say 23%, the 12% of the cases with the anterior wall descent form the contribution to the causes of the bladder outlet obstruction. On the contrary, among the causes of bladder outlet obstruction, 24% contributed by advanced urogenital prolapse. So it's worth always remembering, with increase in the degree of anterior wall prolapse or stage 3 or 4 descent of level 1, level 2, particularly when the BA point in the POCQ is more, there is likely to be more of obstructive symptoms. What is this BA point? And we need to have separate session for that. You see, this is a variable point, which is the most distant point in the prolapse segment. And there is less of stress urinary incontinence. So all of you will be wondering, why is this? With the increase in the BA point, in advanced stage 3, stage 4 prolapse cases, uterovaginal prolapse or in anterior wall prolapse, why is the obstructive symptoms are higher? Why? Because it causes outlet obstruction. How? It causes anatomical distortion and urethral kinking. What does it do? See, you look at this contrast study, you see with the cystocele, there is urethral distortion, kinking, compression, which blocks the outlet, and that is the reason for the outlet obstruction. So, ladies and gentlemen, in a patient with uterovaginal prolapse, advanced stages, with bladder outlet obstruction, and many of them are likely to have sphincter incompetency, which can result in stress urinary incontinence. So as the prolapse progresses, the women notice decrease in the stress urinary incontinence symptom because of the increase in the bladder outlet obstruction. And women with advanced prolapse, the stress incontinence from sphincter incompetency is not revealed, it is masked, and they appear continent. So what really happens is the obstruction, bladder outlet obstruction of the advanced prolapse causes urethral kinking, and it masks the leakage, stress urinary incontinence occurring from the sphincter incompetence. So, ladies and gentlemen, with the anterior wall prolapse or uterovaginal prolapse with sphincter incompetency, when you do the repair for the prolapse, then it relieves the patients from the symptoms of bladder outlet obstruction. But it does not relieve the patient from the symptoms of stress urinary incontinence occurring from sphincter incompetency. Is not only does not relieve stress urinary incontinence, it in fact predisposes the woman to present with stress urinary incontinence. Because once you repair the prolapse or use the pessary, it relieves the patient of the bladder outlet obstruction. So the coexisting sphincter incompetency gets unmasked. So what you see is having the outlet obstruction completely relieved, the sphincter incompetency gets revealed, and there will be stress urinary incontinence. So the question is, when a patient has coexisting cystocele and stress urinary incontinence, if you don't repair both, what will happen? If you don't see, or if you correct only cystocele, what will happen? Or if you correct only sphincter incompetency and stress incontinence, what will happen? These are the situations that we are going to see as case scenarios. If patient has both cystocele and stress incontinence, if both are not corrected, the patient will have progressive bulge and bladder outlet obstruction. She will remain continent because the sphincter incompetency will be masked. Okay. So next scenario is there is coexisting cystocele and sphincter incompetency. If you correct only the cystocele, what will happen? the stress incontinence will get worse because to an extent cystocele is masking the sphincter incompetency. Once you correct it, the stress leakage will be more. So the third scenario is, what if you repair only the stress incontinence and leave the patient with a cystocele? So if you do that, what happens? There will be progression of the cystocele over time, and that will worsen the bladder outlet obstruction. As a result, this is what happens. When you do a successful urethropexy for stress incontinence without correcting the cystocele, then years later, she will gradually develop kinking of the urethrovesical angle because of the progression of the cystocele. So you can see the kinking, how it is demonstrated with the progression of the cystocele. So what happens, what is the reason for the bladder outlet obstruction? In these patients, it may be because of the urethropexy, iatrogenic obstruction, or it may be secondary to the cystocele, or it may be a combination of both. How do we clarify that? So what you need to do is reduce the prolapse with a pessary. Then that will unveil the mechanism of obstruction. And that will guide you to plan your surgery, either to do a prolapse repair or with erythrolysis or without it. So that is very important. So the lower urinary tract dysfunction is something that is part of the descent bulge in the anterior wall. It is not simply an anatomical defect and bulge. It is disturbing the function of the concerned organ. So ladies and gentlemen, do remember this. When there is a less advanced prolapse, there is more of overactive bladder symptoms, more of stress incontinence, and less of bladder outlet obstruction. But when there is an advanced descent, there will be less of stress incontinence, less of overactive bladder symptoms, and more of bladder outlet obstruction. So what is the role of pessary? So in patients who have prolapse, bladder outlet obstruction, and sphincter incompetency, so the pessary currently has a diagnostic and therapeutic value. It relieves the patient from the bladder outlet obstruction, and it reveals the sphincter incompetency and reveals the stress urinary leakage. So ladies and gentlemen, what to do if the patient has prolapse and bladder outlet obstruction, the uterovaginal prolapse? Should I do anything else to relieve the patient from the symptoms of outlet obstruction? No, there is no specific repair technique to correct the bladder outlet obstruction. You simply do the repair, surgical repair, reconstruction, anterior repair with or without hysterectomy. That's all is enough because presence of outlet obstruction, detrusor overactivity, underactivity, they do not change the surgical planning. So ladies and gentlemen, often people wonder when there is a anterior wall bulge and stress incontinence, should I simply address one or address both defects? So we should remember that prolapse causes bladder outlet obstruction. Okay, so the prolapse surgery relieves the patient from the obstruction. Prolapse does not cause stress incontinence or sphincter incompetency. So prolapse surgery per se will not relieve the patient of the symptoms of stress urinary incontinence. This is an important thing one should remember. So when there is an anterior vaginal wall prolapse and overt demonstrable stress urinary incontinence, you need to address both, repair both. So concomitant repair of the cystocele and the sling or whatever technique that you believe in, you have to use. If there is no demonstrable leakage, look for occult stress incontinence. When there is occult, how do you recognize it? You reduce the prolapse with a pessary, and then still if a moderately filled the bladder, if she leaks, it is occult sphincter incompetency and stress incontinence. These cases, you can either do after counseling the patient, you can either do a staged correction or a concomitant correction. So I would conclude by saying, ladies and gentlemen, the primary anterior wall prolapse can be, in majority of the cases, can be repaired successfully by native tissue repair. What is important is not simply stopping short with the plication of the fascia, but reattaching the detached pubocervical fascia back to the pericervical ring. That is absolutely essential. And for those cases where the fascia is detached from the white line, you need to reattach it back to the white line, and that preferably by the abdominal approach. The role of mesh in the repair is only in cases of recurrent anterior vaginal wall prolapse. Beware of the 3M defects, that is multi-level defects, mixed defects, and massive defects. These may form the high-risk cases for recurrence. So, ladies and gentlemen, these are the huge, massive prolapse cases. You see vault and uterovaginal prolapse, and invariably they all have mixed defects and multi-level defects, and we should focus that we correct all the defects in all levels.
Ma'am, sorry to interrupt, ma'am. How many more slides, ma'am?
That's it. I'm finishing. So the complete anterior wall repair involves 3 steps: plicate and reattach the pubocervical fascia, support the vaginal apex, and reduce the genital hiatus. So in the presence of combined stress and cystocele, you have to repair, address both. In the presence of occult, you can counsel the patient, do a staged repair. So with this, I would like to thank the organizing committee for the opportunity, particularly the delegates who were patient enough to listen to us. Thank you.
Thank you, Rajameshwari Madam. This is Dr. Rekha Rajendra Kumar here. It's always a very great moment to listen to you, Madam. It's a matter of enlightenment to listen to you rather every time, and even today. Recently, we had a physical meet from you. That was a great lecture from you in our Jnanavarsha in Bangalore last November. If you remember, we physically interacted, all of us, the members were very happy to listen to you in the Urogynec workshop, Madam. Today also your talk, especially concentrating on the anterior wall defect, was a very important, very practical point, and it was very enriching. And a lot of points you told us about the anterior defect, the apical, the posterior, and all. Every slide had a lot of practical points in that, how to do corrections, the tips, each small defect, and the different combinations you mentioned, how to detect and correct the defects, Madam. Thank you so much. Especially the pictures were very nice and very simple ones, especially for the postgraduates also to learn. Thank you, Madam.
Hello.
Questions?
Rajmeshri, Madam, this is Dr. Shobha Gudi here. You remember, good evening, Madam. You remember I sourced you for the Jnanavarsha program, which Dr. Rekha is telling. And it was really a proud moment when you came, and actually your presence there drew such a huge response from the delegates. I'm very thankful to Vijay for having brought you here. I can also see Dr. J.B. Sharma in the audience. Good evening, Dr. Sharma. And so, Vijay, very well done. And I just wanted to say one last word about Raj Maheshwari Madam's presentation, that I think the part about the bladder outlet obstruction, and particularly the complications of improper repair, your insight is so very important for the delegates. I think these details get missed out, and we all of us do prolapse repairs, but we'll certainly do better if we understand this, because recurrence will be less. So thank you, Madam, for enlightening
There
us.
is
Thank
one
you.
more reason for it, Madam. Actually, Rajameshwari Madam is gynecologist as well as urologist.
Yeah. The
And
combination.
Madam has specialized in
absolutely.
urogynecology, and she was the first person to bring up the urogynecology and bridge between the gynecologist and urologist. So the concepts are of both gynecology as well as urology.
Yeah,
So
Madam.
we are very
He's-
fortunate to have Madam
He's
with
mother
us.
of Urogyne in India.
Easily we can say that. Easily we can say that. Thank you, Madam. Thanks a lot.
Workshop was full day, Madam, and the hall was full because of your presence. Thank you,
Thank
Madam.
you. Thank you.
so much. We keep connected after that also. Thank you so much. I
Thank you,
think
ma'am.
this session is
Yeah, Aarti, if you can go to the next. Are
Thank
there any questions on
quiz.
this?
Ma'am, at the end
There
of
is a
the
quiz.
session, we will have
Quiz.
questions, ma'am.
Yeah,
Quiz.
yeah, fine,
And
Right.
now
fine,
we'll
fine.
have the
Go ahead
quiz.
with the quiz. Yeah, go ahead with the quiz. Yeah.
Namaste,
I have
Sharma.
questions, ma'am.
JB Sharma, sir. Namaste.
Hello,
Rekha
sir.
Raj.
Namaskar, ma'am. Namaskar. So nice to see you, Dr. Soba.
Yes.
Good to you, Dr. Radhamistry. Thank
Good
you.
evening, JB Sharma sir.
Hello, sir. Dr. Vijay Kumar, sir.
Thank you,
Sir,
sir.
I'll start your session. I had to go for an emergency case, but I'll get the lecture
Yeah.
started.
Sir,
But
actually,
I
to
heard
interrupt you.
most of the two lectures. Yeah, congratulations for. I congratulate Dr. Vijay Kumar for organizing this wonderful webinar. Well done, sir. You are very passionate about urogamy. We really thank you and salute you for that. Thank you. Thank you. I'm sure all the PGs and all will be benefited.
Yes, sir.
Thank
This
you,
webinar is for postgraduates only. And before we start the next session, we have a Dr. Rashmi who will be putting up the questions for the previous the topic. This is what we have started of late, sir. Over to you, Dr. Rashmi.
Yes, sir. Thank you, sir. So just to remind for the new audience, there will be a set of 5 questions. I'll be reading out one by one. 30 seconds are given to analyze every question. Do not post the answer immediately in the chat box. Just write down all the 5 answers. Like 1 is this, 2 is this, 3 is this, like that, and keep it ready. And once all the 5 questions are done, you need to post them all together in the chat box. First person to post all the correct answers and as soon as possible will be getting a certificate of appreciation. So I'll be sharing the screen now.
Thank you, Dr. Vijay and Dr. Aarti, for giving us the opportunity.
Thank you, madam. Thank you, madam.
Thank you, ma'am.
Thank you, ma'am. So the anterior wall defects evaluation and the management. So the first question is, in POPQ system, the point BA refers to cervix, posterior vaginal wall, genital hiatus, most distal point on the anterior vaginal wall. Do not post the answer now, just keep it ready. Question number 2. The principles of repair of anterior vaginal wall are all except midline plication of fibromuscular layer of anterior vaginal wall, lateral plication of fibromuscular layer of anterior vaginal wall, site-specific repair with a graft. Question number 3. How common is anterior compartment defect? 5 to 10%, 10 to 20%, 50 to 70%, 25 to 50%. Question number 4. Reason for failure of anterior vaginal wall repair. More elasticity, lifting heavy weight post-operatively, anatomy is such that repair is not adequately possible, failure to restore normal support of bladder. Which is the single best answer? Question number 5. Central defect occurs in 3 to 7%, 5 to 15%, 15 to 20%, 25 to 50%.
It is not visible, no?
Yes, ma'am. Just a minute. Central defect occurs in 3 to 7%, 5 to 15%, 25 to 15 to 25%, 25 to 50%. So kindly post your answers in chat box, all the questions together. Thank you.
Thank you, Rashmi. So all of us will wait till the end to see the
Sure, ma'am.
session. We are already running late. So now I invite Dr. Vijay Kumar. We have our chairpersons, Dr. Sheila Mane, Dr. J.B. Sharma, sir.
Aarti, how will you know that the answers will be for the first session or second session? You will be able to sort out?
Yes, ma'am.
Yes, ma'am.
It is in the chat
The
box.
Okay, fine.
Yes, ma'am. Over to you, Vijay, sir.
Yeah.
Okay.
Due to paucity of time, we are not introducing all the chairpersons and the
Yes, sir.
speaker. We already
Yeah.
we are
Hi,
familiar
ma'am.
with all of them.
Thank you.
Thank you so much.
Yeah.
Yeah.
Shall I start? Am I audible?
Yes, please.
we
Yes.
welcome you.
Yes.
Yeah, we
Hello,
welcome and
madam.
congratulate.
Hello,
Yeah,
madam.
we
Happy to see you,
congratulate you,
madam.
Dr. Vijay Kumar, for organizing this wonderful webinar, and of course, we look forward to your lecture. I may have to go in between for an urgent meeting, and then Dr. Sheila
Sure.
Mane will continue. Thanks. Please, sir. Thank you.
So
Madam.
actually, I made up my mind to pick up this topic, that is the recent trends in the management of prolapse, for a particular reason that the prolapse or the urogynecological problems have changed a lot in these 2-3 decades. Now, as Professor Rajameshwari madam was speaking, we don't see that big prolapse, but we do see the prolapse of the minor severity, and the significance of even the mild form of the prolapse is more among the patients rather than the patients who were having the much more severe pelvic organ prolapse. So pelvic organ prolapse is a dynamic phenomenon. It is not static. What I mean to say is that the prolapse, which will be reducing on itself when the patient lies down, will fall out, and it will be in full flow when the patient strains. So every time the patient changes her position, the prolapse severity will change. Not only the anatomical changes, but also the function of the hollow organs which are there in the pelvis will also change depending on the prolapse severity and the position of the patient. So always it is said that the anatomy and the function or the dysfunction of the pelvic organ prolapse correlates. And we also know that the prolapse is a clinical diagnosis. What I mean to say that when we put up the speculum and hold the cervix with valsalm and pull it out, we can recognize what are the compartments which are at defect. We usually, for our comfort, we divide the pelvic organ prolapse into 3 compartments: anterior, central, and posterior compartment. So when examining, we can make out that which compartment is at more severely defective and which is a mild defective. So why I'm telling this is, this itself is enough for the managing the pelvic organ prolapse. So the pelvic organ prolapse is basically a clinical diagnosis and can be diagnosed and evaluated to the extent clinically. But still, nowadays we are having the other diagnostic tools, especially the MRI. Here you can make out that in the lateral view of the MRI of the pelvis, we can make out a red line passing through the pubis and reaching up to the coccyx. So this forms the line above which usually the pelvic hollow organs will be placed. So what is the significance of this red line is, if anything comes down from this red line, it indicates that the pelvic organ is descending from its normal anatomical position. There is another yellow line also called as H line, which is nothing but depicting the genital hiatus. This also tells that whether the prolapse is coming beyond the level of the introitus or not. So in a way, the MRI of the pelvis is done to identify any minor pelvic organ displacement. Suppose if the patient is not having any severe descent, even after repeated examination, the gynecologist is not able to identify it. But the MRI will be able to detect any minor descent and we will be able to attend it promptly. So here you can see that this is the modification of the MRI, that is the dynamic MRI. Here the MRI is taken during the defecation of the patient in order to note whether the descent is so severe to affect the all organs, especially the sigmoid and the rectus. So dynamic MRI will help us in order to understand the altered function of the pelvic organs. So is prolapse a declining trend? To a certain extent, yes. The number of cases what we used to see in the OPDs 20 years back, we are not seeing the same number of cases of prolapse nowadays. Earlier, the 30 to 40% of OPD cases used to comprise of the pelvic organ prolapse, but now hardly we see the 10% of the cases of the gynec OPD as prolapse. There are various reasons why there is a decline in the prolapse. The one important reason is that the normal delivery rate has come down. Most of the gynecologists, they are taking up the cases for cesarean section, and cesarean section rate has increased. Not only that, even the number of the operative vaginal deliveries, either it could be instrumental deliveries, forceps or vacuum, has come down. Because of these things, the prolapse rate has also come down. So the other aspects which I will be talking are what are the shifting the surgical approaches, as well as what is the recent stand on the mesh usage and the emergence of the need of pessary, and what are the future directions in which the urogynecology is going ahead. So another important aspect, what I am seeing in the recent urogynecology is the apical prolapse is on rise. Even the literature tells that the number of apical prolapse cases are increasing. So what exactly, why is that the apical prolapse is increasing? The one reason is that the hysterectomy has to be blamed for this. So the exact the literature tells that during the hysterectomy, especially the abdominal hysterectomy, the studies have shown that the patients who have undergone hysterectomy for the benign conditions other than prolapse, in such cases, the number of the incidence of apical prolapse has increased compared to the patients who are having the uterus in situ. So, in a way, it indirectly tells that hysterectomy is somewhere the culprit for the apical prolapse. So, what is the exact reason why the patient who has undergone hysterectomy, though not for prolapse, they are having the high chances of the apical prolapse? For this, the uterosacral ligament has to be blamed. As we know that even the previous speaker spoke, the uterosacral ligament and cardinal ligament are the primary support for the vaginal apex, which forms the level 1 De-Lancey's support of the pelvic organs. So the uterosacral ligament during the hysterectomy, especially the abdominal hysterectomy, there will be always a disruption of this uterosacral ligament, which forms the important support to the vaginal apex as well as the cervix. As you can see in this diagram, There are three components of the uterosacral ligament. The component which is marked with the red is the most abundant part of the uterosacral ligament, and it is attaching to the vagina at the junction of the cervix. So this major portion of the uterosacral ligament supports the vagina at its insertion to the cervix. The next common portion, that is about 30% of the uterosacral ligament, actively attaches to the cervix and it forms the part of the pericervical ligament. Whereas a very minute quantity of uterosacral ligaments directly attaches to the vagina, much lower than the apex of the vagina. So in the sense that whenever there is any disruption of this support, that is to the most proximal portion of the vagina, definitely there will be the vault prolapse or apical prolapse in future. This portion of the uterosacral ligament is commonly affected whenever we are doing the abdominal hysterectomy, because during the abdominal hysterectomy we tend to sever this uterosacral ligament, whereas in the other procedures like non-descent vaginal hysterectomy or laparoscopic hysterectomy, this attachment of uterosacral ligament is not disturbed that much. So nowadays, what we see the cases of apical prolapse is because of the previous abdominal hysterectomy and because of the damage to the uterosacral ligament. So as you can see in this pictorial diagram, whenever the hysterectomy happens, there will be a central defect which will be created. So this potential defect is the reason for the apical prolapse. Not only that, even the uterosacral ligaments which are laterally attached will also be not supporting the apex of the vagina. Now, I'll be showing the video which tells how to close the vaginal vault, how to repair the vaginal vault in order to prevent this apical prolapse. The first step in closing the vaginal vault is that you have to include the angle of the vagina with the uterosacral ligament. As seen in this video, the vaginal apex is included in the uterosacral ligament. So when we tie it, the apex is supported well with the remaining uterosacral ligament. So even some of the experienced gynecologists, they will be, while doing abdominal hysterectomy, they will be purposefully fixing the apex with the uterosacral ligament. So this is what is shown in the laparoscopic method. So the angle of vagina is plicated with the uterosacral ligament. Apart from that, the pubocervical fascia and rectovaginal septum, which were separate because of the hysterectomy, will be reapproximated. Here you can see that so in the next step, the pubocervical fascia along with the anterior vagina and the posterior vagina along with the rectovaginal septum is reapproximated. By doing this, the potential space which was created because of the hysterectomy is obliterated and thereby the future vault prolapse is minimized. So when we take a bite, we include both the anterior as well as posterior fascia, that is the pubocervical fascia as well as rectovaginal septum. Again, continuously, the fascia has to be approximated both anteriorly as well as posteriorly. When we come to the other side of the angle, again, the vagina has to be again plicated with the uterosacral ligament, as shown in this video. So the bulk of the uterosacral ligament has to be identified and suture has to be passed through the uterosacral ligament. So this is one of the method in order to prevent the wart prolapse in future, especially when we are doing the hysterectomy. The other methods of preventing the wart prolapse is the mechalkaldoplasty. This is even the NICE guidelines tells that you should never forget to do the mechalkaldoplasty, especially when you are doing the hysterectomy for the prolapse cases, not just the prolapse cases, even in cases of non-descent vaginal hysterectomy, to prevent the wart prolapse in future. The main idea is to identify both the sides of uterosacral ligament. So the video which I have run is the internal mechalkaldoplasty, wherein the suture is taken within the vault. A bite is taken through the uterosacral ligament. And then series of purstring bites are taken through the posterior peritoneum as high as possible. So make sure that you close the pouch of Douglas as high as possible. So at least 4 to 5 bites are taken through the posterior peritoneum. Then it has to be passed through the other side of the uterosacral ligament. So when we ligate it, the pouch of Douglas is obliterated, thereby the enterocoel is repaired or it is prophylactically corrected. The other video is the external mechalkaldoplasty. In the external mechalkaldoplasty, it resembles the internal mechalkaldoplasty, but only difference is that the bite is taken through the vaginal wall as well. So the apex of the vagina is identified. So the apex of the vagina is identified and a bite is taken through the vagina, including the peritoneum. Then the suture is brought through the peritoneal cavity and it is passed through the uterosacral ligament. Sometimes, always there will be confusion how deep we have to go through the posterior peritoneum. We see the epiploea of the intestine, that is the rectum. But if you include the epiploea of rectum, it's fine, but not to include the serosa or muscularis portion of the rectum. So it should be deep enough to take a good thickness of the peritoneum, but preventing the injury to the rectum. Whenever we intend to take the higher portion of the uterosacral ligament, care has to be taken that the ureteric injury is avoided, because the proximal portion of the uterosacral ligament will be close to the ureter and the chances of ureteric injury will be high. So the pursening suture is taken, then passed through the other side of the uterosacral ligament and then brought out through the apex of the vagina on the other side. The advantage of external mecal cultoplasty compared to the internal mecal cultoplasty is that it gives adequate length of the vagina. So it is more ideal in cases of young patients in whom the vaginal length is also very important. You can see that during the conclusion of the surgery, when I approximate it, the vaginal apex is well maintained and the vaginal length is properly maintained. So that is about the mecal cultoplasty. Apart from mecal cultoplasty, there are other preventary measures which can be done, especially when we are doing the laparoscopy or abdominal method. There is the important step called as the Moskowitz procedure. Here in this video, you can see that there is a deep pouch of Douglas, which is nothing but the enterocoel. Some of the video is not running.
So go directly click on the video, sir. If you have it on your desktop.
Just a minute.
Arun, will you be able to help in any way? What happened, Vijay sir?
Sir, can I get that video, sir?
We have another 10 minutes left, sir. Should we take questions in between or?
Vijay, yeah, you want to try once more?
I think he's trying, ma'am.
Can we take
Sometimes
Rashmi's
we
balance
take
questions?
Yeah.
Or Rashmi's balance quiz if it is there, or
Rashmi, are you there? Rashmi?
Yes, ma'am.
Yeah. Can we take your questions by the time they get the
Is it
problem?
visible?
okay, let us see.
Yes,
Yeah,
sir.
it is
Yes, sir.
visible. Yeah.
Yes, sir.
Am I audible?
Yes, sir.
Is it visible?
Yes, sir.
Yeah. So sorry for the interruption. These are the problems what we face in webinars. So this is the video showing that the pouch of Douglas is deepened, and this is nothing but the enterocoel. So I'll show you the Moskowitz procedure, wherein this is done either abdominally or laparoscopically. You can see that the peritoneum over the uterosacral ligament is dissected, and the uterosacral ligament bite is taken. Then the series of purse string bites are taken through the posterior peritoneum, avoiding the injury to the rectum and sigmoid colon. The advantage of the laparoscopy or abdominal Moskowitz procedure is that we can reach the higher peritoneum than compared to the vaginal procedure. You can see that the purse string suture is taken. The basic principle between Meckel cultoplasty and the Moskowitz is the same, approximating the uterosacral ligament and closing of the pouch of Douglas. So here, purse string suture is taken, then it is passed through the other side of the uterosacral ligament. The peritoneum over the uterosacral ligament is dissected in order to avoid the kinking of the ureter, since the ureter is close to the uterosacral ligament. Now, when the approximation is done and ligature is done, you can see that the pouch of Douglas will automatically close. So this is not just the therapeutic, even we can utilize the Moskowitz and Meckel cultoplasty as prophylaxis in order to prevent the future prolapse. This is especially useful when you see the deep pouch of Douglas. As a prophylaxis, you can do the Moskowitz procedure. So the Meckel cultoplasty and Moskowitz procedure are the procedures done for enterocoel, and it can be done as prophylaxis as well as therapeutic. So as the previous speakers were speaking, there are two important aspects in the prolapse surgeries which are very important, and which are the one, those are the one whom most of the gynecologists will forego. They will neglect these two procedures. One is the paravaginal defect identification and its repair. The another one is the distal rectocele repair. So I have purposefully put up these slides because I want to ensure that the most of the gynecologists will not underestimate these two procedures in order to give good result for the pelvic organ prolapse surgery. This is the vaginal paravaginal defect. So in this, what we do, as the earlier speaker said, the pubocervical fascia, which is detached from its lateral attachment, that is arcus tendinous fascia pelvis, is identified and it is reattached. You can see that I have taken a bite through the white line. White line runs as a rope from the pubic tubercle till the ischial spine. It will be a vertical line when the patient is in lithotomy position. So a bite is taken through the white line, and then it is passed through the lateral aspect of the pubocervical fascia. lateral aspect of the pubocervical fascia. About 3 to 4 bites are taken on each side. Now I have taken a bite through the white line and then passing it through the lateral aspect of the pubocervical fascia. You can see that white glistening part is nothing but the fascia. So once it is ligated, you can see that the lateral defect is addressed. Lateral defect is addressed, and since the paravaginal defect is more common than central defect, it becomes very important that you will not miss the repairing of the paravaginal defect. Otherwise, in a paravaginal defect, if you do the central cystocele repair, you are crumpling the pubocervical fascia and you are actually aggravating the lateral defect. This is about the distal rectocele. In the rectocele, there are two important aspects. One is the distal rectocele and proximal rectocele, depending on where it is located. You can see that my index finger is easily popped out through the distal part of the rectum. That is because the pubocervical rectovaginal septum is detached from the perineal body. Normally, the rectovaginal fascia will be well attached to the perineal body, but in distal rectocele, it is detached. So now I am going to identify that detachment and again I will attach it to the perineal body. So the vagina is held with the Alice. Now you can see that there are two important aspects. One is the perineal body or the transverse perineum muscle. The transverse perineum muscle is reinforced. It is reinforced so that the deficit perineum is corrected. Then the distal rectovaginal fascia is identified and a bite is taken and it is again reattached to the perineal body. This is the most anatomical method of correcting the distal rectocele. Then the vagina is closed. So now we will shift our focus to the apical prolapse. So earlier I was speaking about the preventive measures for the apical prolapse. Now, if the proper surgical procedures to attend the apical prolapse. Again, in the modern urogynecology, there has been a shift from laparotomy to the laparoscopy or the robotic surgery. Nowadays, nobody does the open method of correcting the apical prolapse. The reason being that the laparoscopy or robotic surgery is minimal invasive procedures and they avoid the bigger scars on the abdomen. Not only that, even during surgery, the anatomy is better visualized and appreciated in laparoscopy compared to the open method. Not only that, even the patient recovery is faster in laparoscopy. This is the laparoscopic sacrocolpopexy, which is considered as the gold standard for the apical prolapse. Here you can see that the main principle of the sacrocolpopexy is fixing the vault to the anterior longitudinal ligament of the sacrum. So to begin with, we dissect the presacral peritoneum. There are two important aspects in the dissection of the presacral anatomy. One is that there are important vessels, that is the right common iliac vessels and the ureter, which will be running close to the dissecting site. Not only that, even the superior hypogastric plexus will be placed in the presacral peritoneum. So it is very important that we do not disturb the hypogastric plexus of the nerves. So here you can note down, I am not deeply dissecting it, but I am rather making a tunnel in the presacral area, so that the hypogastric nerve plexus which are on the upper portion is not disturbed. Since the hypogastric nerve plexus are important for the proper function of the bladder and rectum, it is preserved. Coming to the anterior, the UV fold of peritoneum is identified and the bladder is dissected well away from the cervix. As I said, nowadays most of the prolapse are done without doing the hysterectomy. It's better to retain the uterus rather than remove it. As I mentioned, the studies have shown that removing of the uterus increases the chances of the apical prolapse. The sacrocolpopexy is considered as gold standard because it addresses all the three levels of support, that is the level 1, 2, and 3 support. Whereas in sacrospinous fixation or in iuterosacral ligation, it is only the apex of the vagina which is addressed, whereas the level 2, level 3 support is not attended that well. So for these reasons, it is more ideal in the patients who are young and who are sexually active. In such cases, the sacrocolpopexy is more ideal. Care has to be taken that the mesh exposure is prevented by closing the peritoneum over the mesh. There are some of the complications of sacrocolpopexy, that is the injury to the vessels or disturbance of the hypogastric nerve plexus and causing alteration in the bladder and bowel function, mesh erosion causing the bowel defect or injury to the bowels. These are some of the complications which can be noted during the sacrocolpopexy. But in the experienced hand, such complications are less and it is considered as much safer procedure. There is other method of correcting the apical prolapse, that is the laparoscopic pectopexy. Here, the mesh is fixed to the pectineal ligament on either side, and the central portion of the mesh is fixed to the anterior vaginal wall. Unlike the sacrocolpopexy, here the addressing the posterior vaginal wall is not that efficiently done compared to the sacrocolpopexy. So we will, when the mesh is fixed to the pectineal ligament, it is addressed more towards anterior rather than posterior. The pectineal ligament is dissected by going in the space between the round ligament and medial umbilical ligament. When we dissect the peritoneum between the round ligament and the medial umbilical ligament, we directly land in with the pectineal ligament. Care has to be taken that we don't injure the external iliac vein, which will be very close to it. The same dissection is done on the other side. Complication wise, the pectopexy appears to be more safer compared to the sacrocolpopexy. In sacrocolpopexy, we will come across a lot of important structures, whereas in the pectopexy, not many vital structures are encountered. So the complication is less compared to the sacrocolpopexy. Again, the disadvantage of pectopexy is that it addresses only the level 1 support and maximum the anterior level 2 support. So the mesh is taken and fixed to the anterior vaginal wall, and the two arms are fixed to the iliopectineal ligament on either side. So coming to the other mode of surgical management is the robotic surgeries. As you all know that the robotic surgery is picking up in very fast pace. The advantages of robotic surgery is that it gives a lot of dexterity and precision. Since the wrist joint is absent in laparoscopy, the advantage of the robotic surgery is that it includes that wrist movement what we get in conventional surgery. Apart from that, there is good 3D visualization of the anatomy. And definitely it's a minimal invasive procedure. And since the learning curve is shortened, even the conventional surgeon can adopt to the robotic surgery. Whereas in laparoscopy, there is a steep learning curve. So for these reasons, the robotic surgery is picking up the popularity. But definitely cost-wise, it is more costlier than the laparoscopic surgery. As you can see that here also the sacrocolpopexy is done, but you can understand that the precision of surgery is very improved, very much significant compared to the laparoscopy. The presacral anatomy is dissected with ease. And you can see that the middle sacral artery which is there can be dissected properly and without injuring it. You can see that the wrist movement, what we are not seeing in the laparoscopy, can be seen in the robotic surgery. And the other advantage of it is you need not depend on the assistant for the camera work. Here, the camera can be moved by the surgeon themselves. And unlike laparoscopy, here, 2 operating ports is enough for doing the complex surgeries. The other advantage of robotics is that it is very much ideal for urogynecological cases wherein we have to reach the deepest portion of the pelvis. So which may not be easy in laparoscopy.
Vijay sir, sorry to interrupt. How much more time, sir?
And the other advantage of robotics is that the suturing it is made very easy with robotics. Whereas in laparoscopy, we have to struggle a bit for doing suturing, especially when we are doing it on the posterior wall of the vagina. Here, the instruments rotates in 360-degree. So the surgery will be more precise and it will be more comfortable. and the other end of the mesh is fixed to the anterior longitudinal ligament so that the vaginal vault is well supported. Coming to the pessary, see, actually, not many of the gynecologists know the advantages of pessary. Since many of the patients are of the higher age group, that is 80 plus, 70 plus, or 80 plus, they may not be fit for surgery in all the cases. In such cases, the pessary has got a very good role. And nowadays we are having the good silicone pessaries. Usually pessaries can be divided into two types. One is a ring pessary, another one is the filling pessary. So ring pessary can be used for the milder form of the prolapse, whereas the filling pessary can be used in more severe type of the prolapse. So again, in ring pessaries, there are various types of ring pessaries. What I am showing the video is the Milex pessary, which is a ring pessary. And most of you will not be knowing what is the exact procedure to place the pessary. Usually the ring pessary has to be folded. Before you take up the pessary, adequate length, the proper length of the diameter of the pessary has to be identified. This is done by placing two fingers in the vagina to note down the distance between the pelvic symphysis and the sacral hollow. The diameter is checked, and then the proper size of the pessary is identified and it is placed by folding it. Once it is in the vagina, the folded pessary is unfolded, then it is pushed posteriorly till it reaches the sacral hollow. Then the proper fitting of the pessary has to be noted. It should not be too tight to cause discomfort in the patient. A index finger has to be passed all across surrounding of the pessary in order to note that it is not tightly fitting. Then the patient has to be made to ambulate, pass urine, so that you can understand that the pessary is very comfortable for the patient. Patient has to be educated to clean the pessary once in 3 months. You can call them for follow-up once in a month, and you can remove the pessary and clean it again, reinsert it. And slowly you can ask or teach the patient how to clean it and self-insert. So nowadays the pessaries are gaining a lot of importance because most of the patients with the prolapse are elderly age group who are not fit for surgery. So few points about artificial intelligence in urogynecology. It is coming in a very big way. The advantages of artificial intelligence is it is helpful in drug treatment selection or in surgical procedures. Many of the patients and even the gynecologists will be in confusion which procedure, which medication has to be put. This will help in identifying the surgical procedure for such patients. Even it is helpful in analyzing the cost benefit. So in conclusion, there is a tremendous shift in the patient with the prolapse presentation and even the symptoms. There is also shift in the choice and methods of surgeries. It has become from conventional to minimal invasive procedures. There is always importance of conservative management, especially in elderly age group, with the use of pessaries. And obviously, there is inclusion of newer tools like dynamic MRI in order to understand the pelvic organ prolapse dysfunction. Thank you.
Thank you, Vijay sir. It was an excellent presentation. So due to paucity of time, I think we will move over to the quiz session. And if time permits, and if Durgadas sir and Shobha ma'am and Vijay sir says, we'll go for the Q&A session. Dr.
Hello, Aarti. Yeah, I was listening. I
Yes,
had
ma'am.
to go for a program today for Rajiv Gandhi University has launched a program for de-addiction program, for the colleges. Anyway, I think it was an excellent program. I was able to hear Dr. Raj Maheshwari and Dr. Vijay. And Dr. Vijay has extensively shown all the procedures. I think conventional, as well as you told about laparoscopy, and at the end even robotics.
Yes.
So that was a real feast to our eyes. And even you also showed the pessaries, which is so
Yes.
important,
Yes.
So only thing is we really don't know sometimes where to get these pessaries, all the good quality ones, and we don't find. I think we can connect with you for that. But I
Sure.
congratulate you for doing this webinar as a chairperson of Kasoga Urogynecology Society. A very good initiative. And I think it will definitely inspire people, to think more about, to take a proper history and try to see that what exactly the patient is having problem. And thank you for giving me the opportunity to chair this session. Thank you.
Thank you.
Thank you, ma'am.
Thank you, ma'am. I think the 2 rounds that we have conducted, if you give permission, we'll announce the answers and the prize winners. Quiz.
You have any questions for this round, Rashmi?
I have, ma'am, but do I have time? Because it will take 2.5 to 3 minutes more.
Vijay sir?
Yeah, sure.
Durgadas
The floor is for Dr. Rashmi.
Okay,
Yes.
go ahead with the questions, Rashmi. Shobha ma'am?
Yes.
Time have we exceeded, Vijay? We have exceeded by
20
22
minutes,
minutes.
Yeah.
Right?
Yes,
20
ma'am.
minutes we have exceeded. And how many audience are there?
I think now
How
we
many
have,
audience are remaining? That is also important.
Yeah.
Half of audience are remaining.
Yes, ma'am.
So shall I
Okay,
announce
Rashmi, finish it.
Okay, ma'am. Thank you.
Finish it.
Yes, and I put up my number. The quiz winners should contact me on my WhatsApp for receiving certificate of appreciation. Thank you. So the first question is site-specific repair. Just a minute. Are you able to see the slide?
No, Rashmi.
Yes.
Yeah, we can see now.
Okay, ma'am.
Again, we are
Yes.
not able to see.
Share the screen.
Yes, I'll share the screen, sir. So the first question is site-specific repair called Richardson's procedure is done for which defect? Cystocele, vault prolapse, rectocele, lax perineum.
Maybe just give 10 seconds, Rashmi.
Yes. Which defect is more commonly seen post-hysterectomy? Anterior, posterior, apical, lateral? Which of the procedures cannot be done vaginally? Sacrospinous fixation, Meckel's pectopexy, posterior colporrhaphy. Which of the following is not a typical type of cystocele? Lateral, apical, distal, posterior? Which type of hysterectomy has recently shown high chance of apical prolapse? Abdominal, vaginal, laparoscopic, robotics? Okay, can post the answers in the chat box.
As you put up the answers, Rashmi, put it off in the chat box too. The winners.
Yes.
Dr. Rashmi, when are you announcing the answers and the prizes?
Now itself, sir. So the prize is a certificate of appreciation.
Yeah,
Okay.
it's a
So
good
the question one,
coordination.
which was, yes, sir. So functional anatomy, which of the following statement regarding the innovation of Levator Annie? The answer was C. It receives innovations from S2 to S5. The D. Lancey's classification level 2 support of vaginal wall refers to attachment of the vagina to the arcus tendinous fascia pelvis and rectovaginalis. Which facial defect is most commonly associated with lateral cystocele? It is detachment of pubocervical fascia from the arcus tendinous fascia pelvis. Which of the following ligaments is commonly used in sacrocolpopexy procedures? It is the anterior longitudinal ligament. And during pelvic floor contraction against increased intra-abdominal pressure, which structure prevents downward visceral displacement? This was a levator plate. This round, the person who gave all the correct answers, there were 4 people. Dr. Prithviraj Venugopal gave the first correct answer. So, sir, you will have to contact me on WhatsApp. I have shared the number. Congratulations. And we have anterior wall defects evaluation and management. The Poppy system point BA, it refers to most distal point on anterior vaginal wall. The principles of repair of antevaginal wall repair are all except lateral plication. How common is anterior compartment defect? It was 25 to 50%. Reason for failure of anterior vaginal wall repair is the failure to restore normal support of the bladder. And central defect, it occurs in 5 to 15%. The first person who gave all the correct answers was Dr. Monica Jayant. Please contact me on WhatsApp for receiving the certificate of appreciation. And sir, the other things, Richardson's, it is for the rectocele. Defect commonly seen post-hysterectomy, it is the posterior one. Which of the procedure cannot be done vaginally? It is pectopexy, it is done by laparoscopic or the robotics. Which of the following is not a typical type of cystocele? It is the posterior. And type of hysterectomy recently shown high chances of apical prolapse is the abdominal route. I'm afraid nobody answered all the questions correctly. So for the third round, there is no certificate of appreciation, but for the first two, we have Dr. Prithviraj and Dr. Monica. Congratulations.
Yeah. Thank you,
Thank you so
Rashmi.
much opportunity.
Thank you, Dr.
So thank you.
Yeah. So, Vijay sir, over to you
Ah.
for the vote of thanks.
Yeah, you only do the vote of thanks, madam. I really
Okay.
thank Dr. Aarti Sridhar along with the other dignitaries. I thank the president, secretary, and the treasurer for being a part of our scientific program. So year onwards, we'll try to do it more frequently, and we'll include more of the speakers in order to make the people understand the urogynecology, and they will be able to manage the urogynecological cases appropriately.
Yeah. Thank you, sir. Thank you all. Thank you, Shobha ma'am.
Yeah,
Thank you.
very
Thank
well
you.
done. Yeah, well done by the team.
Yes.
No doubt, it was a runaway success. You're first. There is no doubt about it. I have absolutely nothing. Isn't it Shobha? Dr. Shobha Pembalgi is here, the treasurer. Hello,
Yeah.
Shobha, you want to say anything? You're muted, Shobha.
Dr. Shobha, you're muted.
Mute agidira, Shobha avare.
Madam, this was really very good idea to start this seminar. where everybody attended. I thank everybody for giving us an excellent talk, and I thank all the members who attended this program and made it a grand success.
Thank you, Shobha ma'am, for joining.
Yeah.
Thank you, Kasoga, for
Thank you, Shobha. I just wanted to caution. I just wanted to caution everyone.
Yeah, madam.
Just wanted to caution. Ha, Srimani madam, yes.
Thank you all.
Thank you, Srimani ma'am.
Srimani madam. She
Thank
started
you.
speaking. Thank you, madam.
Thank you.
I just wanted to caution you all on the time element. On the time element.
Yes,
Please
ma'am.
maintain time. Yeah. So
Yeah.
I think you will have 100% attendance till the end if you maintain